Hi, everyone. Welcome to His Purpose Prevails. My name is Pam, and today I'm so excited to share with you that I have a special guest speaker that I've invited on. And so this is Dr. B. Dr. B and I, we actually met at the Hmong Women Lead Conference in Colorado a few months ago. And she and I, we are both in the mental health field, but she and I do very different things. And so I will get into that a little bit more, but I would like us all to welcome Dr. B. And then Dr. B, if you could just introduce yourself, please.
So, a little bit about myself. I'm a psychologist, licensed in Minnesota and Wisconsin. Let's see, so right now, for the last 5 years or so, I've been doing primarily psychological evaluations. Prior to that, I did a bit more therapy, actually, a lot more therapy, and just a little of psych testing on the side. And that's kind of been my career as a psychologist. Prior to being a psychologist, I'm a social worker as well. So I used to practice primarily under that licensure. That's me professionally. And then personally, I'm a mother, a wife. I have three beautiful children, three sons, and we love to travel whenever we can.
Awesome. Thank you so much for being on. So let's talk a little bit about the differences in what we do. So I'm a licensed marriage and family therapist, but I will often say I'm a psychotherapist or a licensed mental health therapist. So for me,
Mhm.
there's certain diagnoses that I can give or diagnosis that I can give, but some that I can't. So
Yeah.
generally for me at a master's level, I'm not giving out ADHD diagnosis or autism or certain
Mhm.
things like that. So for those things, I would refer out. And so I'm currently practicing with a master's level degree, but you
Mhm.
actually have your doctorate. And so there are different diagnoses that you can give, different tools and assessments that you're giving. And so if you want to share a little bit about the difference, I mean, we can both do therapy, we can both do like talk
Mhm.
therapy. There's probably different interventions and approaches that I use that I'm comfortable with. But for our
Mhm.
viewers and our listeners, if you just want to share like what some distinctions are being a psychologist.
Mhm. Yeah, so when it comes to psychological testing, I would say that that would be the biggest difference between a master's level clinician and doctoral level psychologist is the ability to provide psychological evaluations. And with psychological evaluations, you are right, there are a variety of different assessment measures that we would give. And through that process, then we are, when we do a psychological evaluation, it's not just we give them measures and then they give it back and then we give them a diagnosis. It really is the whole process together. It's the investigation, the time that you spend getting to know the person and investigating, but like really differently than what you do in therapy. Therapy is often a relationship type of work, and
Mhm.
you are really building that relationship and getting at the different challenges that the person might have. And through that, you'll find that, there's a lot of like depressive symptoms, for example, right? And then you might diagnose that with depression. Whereas what we do is we have this dedicated time really
Mhm.
meant to just look at symptom for purpose of differentiation. So it's that kind of intense focus. A psych eval can take up to 8 hours, or some people may even do more.
Wow.
But typically it's like 4 hours, maybe 6 hours max. That's the average. Yeah, and so this is kind of like a deep dive into like their symptomatology and their history and really getting to know them along with the different measures that we would be giving them to give us what we call incremental validity to
Mhm.
kind of give us a little bit more certainty of what the symptoms that they are having, what part of diagnosis that might fall in. Yeah.
Thank you for explaining that. I think that's so helpful for our viewers. And so for me, generally, when I'm referring for a psych eval, there are a lot of symptoms that overlap or they mimic one
Mhm.
another. And so if you're thinking about, I'm thinking about a former client where they were having trouble sleeping, insomnia. Sometimes there was some psychosis, or whether they
Mhm.
felt like they were hearing something or feeling something. And then they had anxiety, but we know that there was trauma, so there was PTSD too. And then we didn't, they're having trouble focusing, couldn't
Mhm.
remember, trouble with school. And so there were all of these factors. And so I didn't have a clear cut answer. And so
Mhm.
for me, I had a working diagnosis, but for me, it was so important to get them referred to somebody who could ask the right questions, give the right questionnaires or, assessments to see what this person had. And it was so important for them too
Mhm.
to be able to identify it or put a name to it. And what I also
Mhm.
appreciate about the psych evals or psychological assessments is toward the end, there's almost like this it's I don't know, you'll have to give me the right word. I don't have one in front of me, but
Mhm.
it's like the outcomes. And so it'll say like, okay,
Yep.
one, it'll give us the diagnosis, right? But then it says this person would really benefit from behavioral therapy, right? Or this
Yep.
person would benefit from occupational therapy or speech
Yep.
therapy. And so those things for me are so helpful and key to to also see if I am the right fit for this client. And so generally when clients are calling me and I'm doing like a free 15-minute consult, if they're saying, yeah, I think I have ADHD, can you diagnose me? Sometimes I may even pause and say, hey, it might be
Mhm.
important for you to get a referral from your doctor, get that sorted out because I may not be the best therapist for you. I may not be the right fit.
Mhm.
So if they're really
Mhm.
wanting to address like that ADHD or, being on the spectrum, then I would say, in my experience, I don't have a ton of experience treating people on the spectrum. So I would say I may not be the best fit. You might be looking for a behavioral therapist.
Mhm. Yeah. Yeah, I think you're absolutely right. I think when we get clients, there are a lot of overlap in symptoms. And as the treatment therapist, a lot of the times it is really hard to sort through that. And frankly, you just don't have enough time
Mm-hmm.
in your sessions to do that because the sessions are typically client centered. You focus on what is relevant to the client. And as a therapist, you could certainly kind of direct that, but much of it is going to be client directed. What is important to
Right.
them. It is their session. And so for you to sit there and figure out all the symptoms and
Yeah.
get it just right, they're probably not going to hang with you.
Mhm.
If they were going to do that, then they would probably look for a psychologist, right, to do the testing and to just kind of figure it out. So yeah, so the work is quite different in that way. And you are right, because of the symptom presentation, several presentations or the same presentation could result in several, like it could be differences, right, in
Right.
diagnoses. So that's why it is really important to get a psychological evaluation, especially for our very complex clients where you're not sure this. I don't know, there's a lot of like psychosis, but there's also mood and
Mhm.
there's also like some personality pieces here. There's trauma. Like,
Right.
what is it? So yeah, certainly that would be very appropriate for a psychological evaluation.
Yes, you and I, we've
Mhm.
chatted on the side and, personally on different things, but I think it's really
Mhm.
important to talk about like the cultural nuances within the Hmong community or even what you're seeing among different cultures. And so how
Mhm.
does people's culture play a role? I know for me as a therapist, if I have a client who's Hmong and they are working on becoming a shaman, let's say there was this illness that precipitated, it was an odd illness, and they are practicing animism and they're called to be a shaman, I'm not going to write down that that's psychosis and that this person needs to
Mhm.
be treated with medication because I understand that's a cultural component. And so how do
Mhm.
you, number one, like conceptualize your cases with Hmong clients, and then how does that play a factor in your assessment?
Yeah, that's a great question. I think um, I think this comes down to both uh, cultural competency and
Mm.
also cultural conceptualization, right? So, what I mean by that is, I think you have to know as a clinician, you have to know enough about that culture and what they, um, the way that they practice, what is considered norm, and what is outside of the box a little bit, you know? And so that would be kind of a starting spot, but it really is, it comes down to also really understanding how they understand what they, you know, what it is that they're experiencing and what they believe to be helpful or healing in those situations. So yeah, you're right. You know, if somebody who is, let's say, Hmong and practices shamanism, and what they are, you know, disclosing as far as their experiences on that path, you'd want to check it out to make sure that that isn't far from the norm, you know,
Mm-hmm.
of what a shaman might experience. And then, you know, and to do that, I think it can, especially if you're not well versed in that religion or that culture, you're going to want to get some information from collateral sources, whether that's friends or family or community leaders. You want to figure out if what they are telling you actually makes sense. Because I would tell you, you know, shamanism is quite complex. You know, I think people who practice shamanism, the average person that practices shamanism, do not know the depth of just how bizarre some of the ideas could get. And I say that in a very loving way, because I
Mm-hmm.
think that the religion is very healing. It's really powerful, but some aspects of it is beyond what some, you know, the average person would be able to understand, you know.
Sure.
So it could get into like the realm of, is this real? Like, can this really happen? And so as a mental health provider, it would be
Mm-hmm.
still important for you to check it out to see if this is still within the norm for a shaman person to be experiencing. So yeah, so you definitely want to check it out and don't just assume that,
Mm-hmm.
wow, the things that they are telling me, it just sounds too far out of reach. Therefore, it's psychosis, because you might
Right.
not, that might not be the case. Yeah. And then I think the other thing does come down to kind of more Western practice of, you know, you got to look at the functionality of the individual, right? And what it is that they're saying. If they
Mm-hmm.
are claiming that they are, you know, having psychosis, but then they practice shamanism, like, you know, you got to look at, is this person functional? How do they fit in into the
Mm-hmm.
community, into their families as a whole? What do people think of them? Are they somebody who is identified as, you know, somebody who is a leader in the community, who
Mm-hmm.
knows what they're actually talking about? People are seeking them out? Or is this somebody who actually people are thinking, no, they're a little bit outside of the norm, you know,
Mm-hmm.
and maybe they struggle in multiple areas of their life that would suggest that maybe this is a little bit different than shamanism. Yeah.
Yeah, thank you so much for that piece. Can you explain a little bit more about psychosis? I know that you and we've talked about it, but maybe people don't know what psychosis is or what would constitute psychosis. So if you want to share a little bit more about that.
Yeah. So psychosis, generally, it has to do with reality testing. How, you know, how far off are they from reality? And
Mm-hmm.
I get it, everyone's reality is a little bit different. But what we're talking about is, you know, the things that they are saying, is that plausible? Is it, can it actually happen? Is it reality based? Or
Mm-hmm.
is it so different that it's no longer within the realm of, this is concrete, this is accurate, other people see it the same way that they see it.
Mm-hmm.
So there is a degree, right? So it just
Mm-hmm.
depends on what that looks like. Another piece that has to do with psychosis is hallucinations. And again, that continuum of, so hallucinations could be all sorts of hallucinations, usually generally things that are taken in through the senses. So things that you see,
Mm-hmm.
things that you hear, things that you feel or taste and smell. And some of that, you know, it could be internal. Usually the
Mm-hmm.
hallucinations are internally generated. And that's where you would get psychosis. So, you know, are these, let's say, visual hallucinations? You're seeing things. Is this something? So, as a clinician, you're asking, is this something that is internally generated, or is it actually external where other people would experience it exactly the same way too? So yeah, there's always kind of a continuum. So you'd want to check it out to make sure that you're really
Mhm.
understanding the degree of presence of that and the effects of the psychosis.
Okay. Thank you. Yeah, thank you. I think sometimes, I feel like Hmong people, we can be very spiritual. And so if we're
Mhm.
seeing or hearing things or even like dream
Yeah,
interpretation, we we would assume it's this and not this. And so sometimes parents
yeah,
can normalize certain behaviors or they don't know what to do. And so they just say this is what it is and they don't know that there's help and resources.
yeah.
And so, in your job as a psychologist, have you ever had any pushback from clients or they're like minimizing something where you're like, hey, actually, this really is significant?
Hmm. Yeah, before I answer that question, I want to go back to that piece about psychosis because there there are many situations, non-mental
Mhm,
health related, where somebody could experience just have psychotic or just kind of out of touch
mhm,
from reality types of experiences. Okay,
mhm,
those things are perfectly normal. It is absolutely normal to have an experience, especially, okay, so I think everyone at one point might have experienced this. As you're waking up from sleep or falling into sleep, you might experience where your reality testing is a little bit blurred and you
mhm,
hear things or you see things and you're like, oh, I don't know if I actually experienced that. Um,
mhm.
Experiences like that is perfectly normal. If you're taking certain medications that can induce psychosis, that's perfectly normal. It does not mean that you're psychotic. Okay, so I
Mhm,
just want to differentiate that. When we're talking about psychosis or psychotic disorder, we are really
mhm,
talking about the frequency at which that happens and the
mhm.
impact that it has on your functionality. Okay, so just to make it clear that just because you experience that does not make you psychotic.
Yeah, well,
So,
and
mhm,
I'm even thinking of when, and maybe this is not related to psychosis, but I'm even thinking of when
uh-huh,
something like a major grievance happens or something
mhm,
like you catch your partner cheating in the act or
yeah,
your loved one dies unexpectedly. Like those are when we have these behaviors that we normally would not because
mhm,
this event hasn't happened. And so I know that, if you think of grief or loss, like losing a loved one would make a person grieving maybe not want to live anymore. Whereas if that had
mhm,
not happened, they would not have suicidal ideation. And so I don't know if that
yeah,
plays a factor. And then there's also like
uh-huh,
drug-induced psychosis too, where if
yes,
you were not using or abusing, drugs or substances, you may not
yep,
have um those experiences as well.
yeah, yeah, and it always comes back to the impact, the severity of what it is
Mhm,
that you're experiencing. So, for example, if you like a spouse cheats on that person and they
mhm,
have a psychotic break, okay,
mhm,
that certainly can be psychosis.
mhm.
Even if it happened the one time. But we're talking
Yeah.
about like the severity of it and the impact that that has, right?
Mhm,
So we always want to be looking at that. It's not, I know it's not clear cut, but I think that
mhm.
this is why it's important to see a mental health professional who could really help with that differentiation.
Yes. Yeah, and it's so important because people, we have TikTok, we have social media, and so a lot of people are throwing around these terms. Like one of the major hot button topics or hot trending terms is narcissist. And I hear people
Yeah.
saying, I'm in this difficult relationship with my husband. We've been together 10 years. He's not meeting my needs, and he is a narcissist. And I'm like, was
Hmm.
he a narcissist when you first married him or just now? But it's because
Hmm.
they're not getting their needs met, and there's all of these videos out there. And I do explain, and I have to say, I educate them and say, for a
Hmm.
person to have narcissistic personality disorder, they need to meet
Hmm.
criteria. And I think we are throwing the term around very flippantly. And I also
Hmm.
say we all have narcissistic traits
Hmm.
on one level or another, but that doesn't make us all narcissists. But I know I'm giving you a few questions, so feel free to circle back and
Yeah.
answer. Yeah.
Yeah, I agree. I feel like, especially in a long marriage, like if you've been in a relationship or a marriage for a long time, everyone starts becoming a little bit narcissistic, right?
Yeah.
Because I think we're trying to get our own needs met, and we've passed the phase of, oh, we're all about the other person. Now it's
Right.
okay. Yeah, right. So yeah, you are right. We want to be careful about what we are gathering from social media and just things that we are hearing, checking out to make sure that that is accurate. I think we're also looking at persistence, going back to like the impact, but also the persistence of those issues. And yeah, so that's all going to play a role in how we diagnose. I want to so then going back to your question about symptom minimization, or maybe not fully understanding or minimizing some of the presentation. And when in fact, it really is a big issue, a big
Right.
issue. I'm thinking about, because a lot of my work, I do a lot of, it seems like a lot more neurodevelopmental the more that I do psych evals, And when I say neurodevelopmental, I'm talking about usually conditions that result from brain differences. And
Mm,
these would include disorders like ADHD, so
mhm,
attention deficit hyperactivity disorder, autism spectrum disorder, ASD, along with, like intellectual disability, language communication disorders and whatnot. So these
mhm,
are differences in the brain. And I would say that while it is true that mental health disorders could also be minimized, like
mhm,
depression, I think I feel like the Hmong community has gotten to the point where the people that are maybe are more acculturated or more progressive, they
mhm.
understand the concept of minimizing like depression, for example, that certainly the culture and individuals within the culture could certainly minimize mental health like depression when in fact
Right.
it really is a thing. Okay.
Mhm,
It's really the neurodevelopmental disorders, I feel like, that is still not even on the radar
mm,
of our Hmong people yet. So
mhm,
what I mean by that is I'll have clients who come in who are, so I work with all ages, but usually with this group for the neurodevelopmental, they're usually younger kids. I work with another psychologist who does the itty bitties, so I don't have to do that.
Yeah.
So he usually tests the 0 to 5 category. It is
Mm,
a specialty for early childhood. So then I usually test like 6 to really upwards, right?
mm,
So in that group, I would say from 6, 7 years old until like teenage age, when there is a neurodevelopmental difference, I do see that there is, especially in our Southeast Asian populations and in particular our Hmong populations too, there will be a minimization of certain symptoms, if you will, or certain
mhm,
presentation. And they might say that that is typical or that's normal, or they might not even, that might not even be on their radar as being problematic. And
Sure.
it really is. So
Mhm,
language is a
mhm,
big one where they will say something like, and this might be like a 10-year-old, right? Where they said,
mhm,
oh, they've always been quiet. They've always been shy. They talk, but they'll always give me like 1 or 2 word answers. And that's normal for them. And then not think that there is a problem there.
okay.
By the age of 10, somebody who has normal, if you will, language should be able to converse
Mm,
and give you more than 1 or 2 word responses, even if they are shy, even
mhm,
if they are more introverted, they don't say a whole lot. When you have a one-on-one conversation with them,
mm,
especially somebody close to them where they should feel comfortable with, a
right.
mother, a father, a grandparent, sibling, they should be able to give you more than a couple of word responses. So
Sure.
it's usually times like that I'm like, nope, this is a real issue here,
Mhm.
and it needs to be addressed. So let's not minimize that. That is a real condition. So yeah, so
Yeah.
I feel like that's where I feel like for our Hmong people, it's still really off the radar.
Yeah, because I'm hearing that maybe the parents and or guardians are attributing it to temperament or like personality
Hmm.
traits. So they're saying like, oh, they're just shy. They're just a person of
Hmm.
few words. But you're saying, no, if this person is around someone like a parent that they feel comfortable with and they're only giving one word answers, then we want to look into that. Because yeah,
Yeah.
especially if it's by the age of 10, they should be able to
Yeah.
have complete sentences and have the back and forth.
Yeah. Yeah,
Yeah.
and I think this comes back to what the conversation we were having earlier about cultural conceptualizations, right? Of
Hmm.
and I think it's so complex. Cultural conceptualization is so complex. Um, you
Hmm.
know, so we have to also take into consideration the history of the individuals that we're working with. So if we're talking about like the case of a Hmong person, we have to talk
Hmm.
about the immigration history. When did they come to the US? Was the child born in the US? Was the
Hmm.
child educated? So we're looking at now English instructions or language instructions. Was that done in the
Hmm.
English language? How did that impact the individual? How did they learn?
Hmm.
Was that, a part of their instructions, or did they come later and maybe they didn't get any formal education until they were 8 years old? So you
Right.
have to really take that into consideration when you figure out, what might be going on. And then I think another thing too with cultural conceptualization is how the family or the parents, what do they know, right? Like because of immigration and acculturation issues here, what are they aware of in terms of developmental differences, but then also, so conceptually, developmental differences. And what I mean by that is here in the US, you are
Hmm.
trained, like especially as a new mother, you get like a whole training about what is typical, and with
Right.
well child checks, the
Hmm.
doctors are really good about telling you, oh, at this many months, your child should be doing this and this. That's a cultural conceptualization. We were taught that. Okay.
Right.
And back in Laos and Thailand, there was kind of like a general understanding, but it was never broken down into steps of months.
Yeah.
When your child was able to do this. And so that's a cultural conceptualization. And
Hmm.
so when family or when parents aren't necessarily aware, like there's not specific timeframes that they are looking at to understand their child's development, that's going to
Right.
look differently from person to person. Okay.
Yeah.
And then coming here to the US, they aren't, many of our parents and grandparents, they don't have an understanding of just the healthcare system and mental
Hmm.
health, and what are the resources and services available, and when is it that somebody would be deemed eligible for services, so if somebody
Hmm.
is maybe delayed, um, how do you even know that that is a thing here in the US?
Hmm.
If you never had that in your own country, in the way that you were brought up, how do you even know that that is a thing? And
Right.
then if that is a thing, like how do you even know like where to go, or how to even start getting services? So yeah, there's a lot there with cultural
Hmm.
conceptualization.
Yeah, I think of, even my parents and my in-laws when they first came to the States, yeah, they had kids and they had to catch up on, immunizations or vaccinations and things like that. But I know for me, I'm very like, okay, 3 months, 6 months, 9 months, right? And you're really
Mm-hmm.
on track. But Hmong parents are busy and they're trying to assimilate and they have, some of them have 6, 8 kids. And so they're trying to keep up with everything that they're not taking them to every visit on time at least, right? Maybe it's
Yes.
one visit and they're catching up on 2, 3 vaccinations.
Mm-hmm.
And so you're right, they are not programmed in a way or conditioned to track these things and they're not
Mm-hmm.
like documenting or tracking the milestones that we are
Mm-hmm.
probably now that we are having children and we know like okay there's a 3 month well visit, there's a 6 month, there's a 9 month and so forth. So yeah, I
Mm-hmm.
think you brought up a really important point there.
Mm-hmm. Yeah, yeah. And I think that that's important for us, and that's something that I constantly check when I do psychological evaluations, especially with our BIPOC and Southeast Asian, specifically Hmong families.
Hmm.
Because when I say, when we ask questions about developmental history, this is like a nuance where I think a clinician of that culture, like a psychologist in that culture, is going to do, in many ways, a much better job at because that culture, the way that they do things.
Yeah.
So when I ask about development, and if they give me a response like, "Oh no, they were fine, nothing significant, they were typical," or like
Yeah.
the word typical is loaded too, but yeah, they'll
Yeah.
say, "Yeah, everything looks fine, looks normal,
Mhm.
right?" And I would want to dig a little bit more into that to figure out when you say normal, like what does that actually mean? And so you will really want to figure out, well, when did they start laughing or noticing you?
Mhm.
When did they start like smiling and giggling?
Mhm.
And when did they start sitting up? When did they start walking? When did, and so on.
Right.
Um, and you come to find out, and I would say that in general, all psychologists, if you're doing a thorough evaluation, you're going to be asking these questions too. But
Okay,
I
good.
think being able to catch some of maybe the nuanced ways in which most people might say things
Yeah.
is important. So that's why I think I always push for, if we could get more BIPOC providers in the
Right.
psychology field, that'd be great. So yeah, that's my soapbox. But yeah, so I think really getting to the nitty-gritty of what they mean when they say everything is normal. And usually come to find out parents might not be able to tell you exactly when they
Mhm.
started to talk. Were they talking one word? Like, what was the first word? Those are really hard for our both families to say. But I think just if you could get a good grasp of when language was able to be developed and they were able to communicate in a way where you could actually understand them and use
Mhm.
sentences, I think that that's good indicators. And for some families, they might say, yeah, that wasn't until like they were 5, and they call that normal because they had language prior to that.
Right.
And it's like,
Right.
well, we're not talking about the same thing here then. Yeah.
Yeah. No, that was going to be a follow-up question too, is like, you know to look for these things, you hear things, and then you know to ask more questions or to dig a bit further. But if we have non-Hmong colleagues or counterparts and they're not asking these questions, that could be a disservice. Not to devalue, to say
Mhm.
non-Hmong psychologists are not doing their job, but like it's almost like you have an ear for it. And I'm wondering like how we would train other psychologists to have an ear for it, or do they just accept what the family members or what the person is giving them?
You could certainly train for it, but I do think that there are diversity within groups too. So not all Hmong people are created the same, right? We don't all have the
Yeah.
same experience. So there could be variations, right? So you could certainly train um, for just to be able to do a better job at
Mhm.
assessing and asking the right questions. But I would say in general, when you have somebody of the same culture, the same language, of similar experiences, you have a better way to just pick up on little nuances in the way that people do things, the way that they say things, that could make all the difference. Um, so just a very concrete example. I actually just had a client who I recently tested.
Mhm.
This is among women, older women. And she
Okay.
was tested by the same measure that I had used, but several years ago.
Mhm.
And she actually performed, the outcome, the overall outcome is still in the same range. But,
Mhm.
and people certainly could perform a little bit better, a little bit worse, depending
Sure.
on the date, on the same measure. And I get that. But
Mhm.
the last administration, she was about 10 points, yeah, about 10 points lower
Okay.
on one of the subtests that I had tested her on. Again, not a big difference because overall it still came out to be in the same area. But I did wonder when I administered that, if language made a difference. And what I mean by that is the previous one was done by an interpreter, or the use of interpreter. And what I noticed about there was one subtest that she did particularly well in, right? And when I gave the instructions, and it was standardized instructions, the word
Yeah.
that she used back, okay, to kind of help her understand was she said, "Oh, so what we're doing here is," and then she repeated the instructions, and then she says, "So what we were trying to do is group." So the task is there's two items that are the same, and then there is a third item that needs to be put in the same box to make those three items the same. And they have like
Oh,
a
sure.
selection to pick from, right? And
Yeah.
so she says, so I gave her the instructions, the standardized instructions, and she said, "Oh, okay. So what we are doing is we're trying to pick one item from the options so that these three could be each a name, one family." Okay.
Yeah.
And I
Mm-hmm.
said, "Yes, that's exactly what we are doing." And so that was her conceptualization of, oh, each
Yeah.
name means they all belong together,
Mhm.
whereas the words that I was using was, pick the item. So that go pe kondona, the three items, zhong shisu. Okay, so
Yeah.
are alike. Okay, because that's
Yeah.
the closest word. But when she said,
Yeah.
"Oh, so like pick your each name," I
Mhm.
think that I wondered if that word made all the difference, actually.
Right.
And she was able to do much better, or not much better, but 10 points better in that
Yeah.
particular subtest. So it's things like that I do wonder. And I don't know that the interpreter, because they are, even if they are, and this is why so off on another little tangent here, I've certainly
Yeah.
worked with interpreters too during testing, because I test not just our Hmong people and English speaking people, but I also test whoever comes through the door. And many of the organization that I work at we serve a largely diverse community,
Mhm.
and many of them speak different languages. Many of them
Mhm.
are Southeast Asian. So I've
Okay.
certainly used interpreters, and I've also used Hmong interpreters. And what I picked up is that even though they are trained in the medical field, they are a
Mhm.
medical translator,
Mhm.
when it comes to these technical aspects, when we're doing psych testing, the translation, the interpretation, if even for them, it's very challenging.
Right.
They aren't necessarily gonna, and they aren't trained in the way that we do things, so they're not gonna fully, like, I'm just assuming that if that word iching would have been used at the previous administration, that the interpreter would have known that,
Mhm.
oh, that word is significant clinically to make the
Mhm.
difference here.
Right.
So it's things like that. So I do think that we do have better training for interpreters, but even then, that's where I think somebody like a clinician, psychologist who is just well versed in that culture, that language, could really make a difference.
Absolutely. Yeah, I mean, they're being administered a test or measure, but they have to understand what
Mhm.
they're doing. That will make all the difference, right? And so,
Yeah.
that's so important. So, yes, we definitely need more BIPOC clinicians. I know that there are some Hmong psychologists, not all of them are doing testing. And so I was
Mhm.
so excited to like dig in with you and jump in about talking that I
Mhm.
really didn't ask about your journey. And so if you want to share a
Mhm.
little bit about like what was your journey transitioning from being a social worker and saying like, yeah, I want to
Mhm.
go back to school to be a psychologist.
Yeah, thanks for asking. I think I've always been fascinated by the human experience, how
Hmm.
people's brain works, and putting puzzle pieces together to understand someone. So from that aspect, I've always had that in me, as a clinician, as a therapist. That's what I often do. I think we often do that, when we work with someone. It's what are the missing pieces? How do we work with that? So that really was what got me to go back to, for my psychology degree, for this fuller understanding and for the
Hmm.
psych testing. But I have to be honest, when I went back, even though I was so curious about psychological evaluations and testing, it was a very intimidating field for me. I didn't necessarily want to do that as
Yeah.
my career. And I would say, and I've worked with enough. I also, so a little backstory too. I do training. I train a lot of BIPOC folks, doctoral BIPOC folks for psychological testing too. So at this point, you know, I think I've gotten to the point where this really isn't this the fears that I was experiencing at the time is not exclusive to me. I would say in general, our
Mhm.
BIPOC folks are intimidated by the psych testing field. Okay,
Mhm.
for many reasons. It's not just that it's not just the work, it's also the written portions of it, because after we test them, that's the fun part. That's the very fascinating part that everyone wants to go in for.
Right.
At the end of that, the output is a report. So
Mhm.
that's, I think, the written part is very, I think, intimidating and overwhelming too. So, I when I went in, I think those were the same things that I was struggling with, where I was like, I don't know if I could do this. I want to. It's so fascinating to me, but I don't know if I could do this. And I've had really good training all throughout grad school, postdoc, and and even then, I was so comfortable and I really love therapy. And that
Mhm.
was really going to be my bread and butter. And I was
Yeah.
just going to be a psychologist who could claim that they have psych testing experience.
Uh,
And I could certainly do it. I just am not feeling comfortable enough where I could say I could do it independently. And it wasn't until I landed my current position, actually, where so again, I work at a very diverse, like we just received very diverse clients. Okay. And when I went in, I'm like, I'm going to be a therapist. I can't wait to be a therapist.
mhm.
Because as we all know, there's such a need for BIPOC therapists, right? So I'm thinking, yeah, that's my comfort. I'm going to go in. And come to find out, this place already has several BIPOC psychologists, many of them Hmong, right? So I'm
Mhm.
like, well, that job is taken care of. And
Uh-huh.
then I'm like, I'm the only psychologist that could do psych testing, and there is no one, let alone a BIPOC person, doing psych testing. So I'm like, you know
Mhm.
what? I'm just gonna do it. I'm just gonna do
Mhm.
it. It's either I'm gonna just really suck and fail and like put this
Yeah.
aside, or I'm gonna just get very comfortable with it. Who knows? And I'm so glad I did that. I just took the plunge and I started doing it just full time. Prior to that, I was doing it, and I would have to say that, just even to back up a little bit, the way that we are trained with psych testing, maybe
Mhm.
another aspect too, is historically psych testing has always been with Mikadang. Okay, so white
Yeah.
individuals, even the norms are standardized on
Right.
our white population.
Mhm.
So, and the training is done in that way too. So, in many of our training, even now,
Yeah.
our academic programs are trained, uh, are training students to do this with primarily white folks. Okay, so the training isn't adequate to serve our BIPOC population, right?
Yeah.
And so that is part of the challenge. Is I could do this and I could do it comfortably with a certain subset. And that, I think, that was part of my worries too. And then, yeah,
Mhm.
so then now at my current agency, I just kind of plunged into it and have been doing this with really great supervision, I have to say, support and supervision to do what I am doing, and to the point where I'm like, I love this. I'm so glad
Yeah.
I did this because it's so needed, and I feel comfortable and I feel like I'm really making a difference, especially with our BIPOC folks. And as I mentioned, I get the opportunity to train. So I'm located in the Twin Cities. And so I
Mhm.
train, there's several colleges in the area that have doctoral psychology programs, and they're always looking for practicum sites. And so I train a lot of students that come through, and it's just been
Awesome.
just so rewarding. Yeah.
Yeah, I mean, you're saying it's so needed. Dr. B, you're so needed. I think that because you live in an area where there is a large Southeast Asian population, there are a lot of psychologists, but how many of them are really doing the psych testing? And so you are an asset. It's what you're doing is so valuable and so important. So the Twin Cities, they are really extremely lucky to have you.
Yeah, thank you. Yeah, in general, there's not a lot of Hmong psychologists.
Hmm.
And then when we narrow it down to psych testing, There's
Mm-hmm.
even fewer, maybe less than five, who are licensed and who are doing this work in the field. And some of them may not even be accessible, depending on the settings that they might be in. So yeah, it really is quite a need out there.
Can you tell me the difference between like a psychological assessment versus a psychological evaluation? And then there are other doctors, but they're medical doctors, but they're also able to administer these tests too. So like when would somebody go to a psychologist versus like somebody in the medical field with a PhD?
Yeah. Uh-huh. Yeah, great question. So I use assessment and evaluation interchangeably.
Okay.
So when I say psychological evaluation, psychological assessment, I mean the same thing. Um,
Okay.
there is, though, a difference between psychological evaluation and neuropsychological evaluation. Certainly, a neuropsychologist or someone who does neuropsychological evaluations could do regular psychological evaluations. I would say so. Or neuropsychological evaluation is a specialty in that you need additional training and even board certification in that area. So for when I say psychological evaluations, that's more like a generalist term
Mhm.
for just generalist psychological evaluations. Okay, so even though, and this is where it gets blurry, right,
Mhm.
for our testing folks. Even though you are a psychologist and you do just more generalist psychological evaluations, it just depends on your training. You could certainly do neural psychological evaluations, including ADHD and ASD types of evaluations. But really, a neuropsychologist is somebody who is would have the in-depth knowledge of the brain and the way in which the brain works and how all the different areas of the brain work together and the different areas. So it's more focused on the brain functioning and how that impacts functioning. Yeah. Whereas like a psychological evaluation would be more focused on, it could be brain, it could be um, personality, it could be social environmental
Mhm.
factors, it could be emotional functioning, all kinds of things. Yeah, so kind of more
Mhm.
of a broad brush for psychological evaluations. What you said about why, like, what's the difference? When would somebody go to a
Right.
psychologist for a eval versus like a, yeah, so there are a certain subset. So there are, when we talk about psychological measures or
Mhm.
instruments, there are a wide, it's like on a continuum as well too,
Mhm.
right? There are
Mhm.
certainly measures that any clinician, master's level, or really anyone who is in that field could administer, like BDI or a BAI. Those are certainly psychological measures too. BDI and
Mhm.
BAI are just short inventories, questionnaires. BAI is for anxiety, BDI is for depression.
Right.
For adults, it's just a questionnaire. Any mental health provider could administer that. So then on the continuum, there are a subset of measures
Mhm.
that only psychologists are trained in administration.
Mhm.
So these would be more of the what we would call standardized measures, and these
Mhm.
are things like cognitive measures to neurodevelopmental measures, like ADOS, which is used for autism testing, some achievement measures for academic performance. So
Mhm.
there are a subset of measures that's very standardized, and these
Mhm.
are where this is kind of the bread and butter of psychologists.
Mhm.
So where do you go, right? If you're
Mhm.
a doctor, like maybe even a psychiatrist, where you go for just medications, mental health medications, or maybe even your doctor at the doctor's office, your PCP, might be giving you some measures to complete. Certainly, they could do that, and they could certainly prescribe based on those measures,
Mhm.
but they aren't in the position to do a thorough psychological evaluation to really determine what is the etiology or the root of the
Mhm.
issues. So I've had several conversations with psychiatrists, the individuals who give medications in the mental health realm, right? And they'll send referrals our way. And what they'll say is, this person came in for ADHD medication. They think
Mhm.
that they have ADHD. I don't know, it sounds like it, but I'm going to send it to you for, diagnostic clarity. And the
Mhm.
reason why they might do that is because, you know, back to our earlier conversation, a lot of things can look like ADHD.
Right.
Trauma, for example, could look like ADHD. Just the way in which the person is brought up could
Mhm.
be like if the household is chaotic, there's really loose rules in the house,
Right.
can look like they have ADHD. So anyway, it's really the psychologist that would be able to spend the time to really do that thorough investigation along with
Mhm.
the administration of the different measures to give it more validity, that
Mhm.
diagnosis more validity.
Yeah, so things like Alzheimer's or dementia, somebody wouldn't be coming to you for that diagnosis. Would they more likely go to a neuropsychologist for that?
Yes, exactly. Yep. So that is a specialty. So, certainly a generalist psychologist, as I was saying, if they have the
Mhm.
experience, they could certainly diagnose that. And if it is
Mhm.
very probable, because we of the investigation that we do, we would, it's possible that we could rule out what it isn't,
Okay.
and then we're left with what might it be. And that might be
Sure.
a good time for the person to go to a neural psychologist. Or if we're thinking right off the bat that that's what it is, then they could certainly go directly to a neuropsychologist for the more in-depth look. I've certainly had several clients who come through where they're really not sure if this is like a neuropsychology eval, or if this
Mhm.
is more mental health related, like more psychological, general psychological evaluation, because the
Mhm.
person is just so complex. There's certainly been falls and head injuries,
Yes.
but nothing like super significant where they were like in a coma for weeks or days or nothing like that. But certainly there's head traumas. They've been abused. They've been through this and that, and so it's just a very complex
Mhm.
web. And
Mhm.
then what we'll do is we'll maybe go through. We'll tell the client, look, we could do kind of like a first pass at this
Mhm.
evaluation. We'll kind of narrow it down, to see what
Mhm.
might be what is coming up, what might be the more prominent presentations. And then we could certainly, like, if we don't answer or we don't give you exactly what you need in
Mhm.
terms of like more specific maybe recommendations, then we could certainly refer for neuropsych eval to just get more clarity in those areas.
Sure. I really want to go back to a point you said earlier that I think it's really helpful. So I appreciate that you bring up that you don't prescribe medication. It's
Mhm.
psychiatrists that do. I'm a mental
Yes,
health therapist, so I don't prescribe medication. And
yes,
sometimes that's often what I notice my BIPOC clients, because they have that relationship and that rapport with you. It's almost like they would like you to be able to prescribe medication too, because some of my clients don't have a PCP. They don't have a primary care
yes,
provider. But even you with a doctorate level, you don't prescribe medication. So it's psychiatrists, PCPs can prescribe certain medications if they feel comfortable. And then
yes,
like nurse practitioner level, right? They can also
yes,
prescribe medication if they have that psychiatry training.
yes.
So,
Yeah, in the field of psychology, and actually, quite an active debate going on right now. Some states are actually allowing psychologists to prescribe. So
okay.
you could certainly go in and get additional training and
Uh-huh.
licensure
Hmm.
to do prescription. My personal take on that, at one
Hmm.
point I was really interested, actually. I was like, oh, that would be fun, to like do that and do psych testing. You could be like a one-stop shop, right? But the
Hmm.
more I do psych evals, the more, I'm in this clinical work, I my personal feelings about it has changed.
Hmm.
And you know, I think it kind of goes to how nice would it be to just pass
Hmm.
the person off and
Yeah.
they could get somebody who is really a specialist in that area, who could really manage that long term, because that's what a
Right.
psychiatrist is going to have to do. They're going to have to, like a prescriber, they're going to have to manage that. long
Mhm.
term in most cases, you know.
Right.
And it would be really nice to just let that go, you know.
Mhm.
But I think also a conflict of interest, in my opinion, you know, after you've evaluated somebody, um, you know, you don't have that, you know, to be able to pass that on, the individual on, so that you don't have just the information that you found out, you know, from the evaluation, to
Yeah.
clutter your brain so that you can
Right.
do a better job at just treating the symptoms. You know, so
Right.
I think for me, I am taking those things into consideration. And I, even if it became available in the state of Minnesota or Wisconsin, I that would not be something that I would likely pursue.
Okay. Thank you for sharing. Another question I have, in your experience, what has been the attitude of like Hmong clients seeking treatment and or services? And so I think we know that there's a shame and stigma in the Hmong community. We know that in the hills in Laos, there were no psychologists or mental health therapists,
Mhm.
so that's not a norm for them. But when people are, when they're doing their intake or they are being referred or sent to see, what is their general attitude when they come in?
Mhm. You know, it just really, well, you know, currently the clients I work with, they are all internal referrals, meaning I'm a
Okay.
psychologist at the agency, but the
Hmm.
referrals I get are within the agency. So case
Okay.
managers, therapists, psychologists, or psychiatrists,
Hmm.
some psychologists as well too, would refer them in for psych testing. So they are already in the system. They are
Okay.
already receiving mental health services. So I feel like that is a little bit different. But in other settings that I've been in, where
Hmm.
it is, you know, we take any external referrals, you know, I think the attitude is a little bit different too. Certainly, stigma is shame is still there. I think that that is certainly what can prevent somebody from coming in. But I also find that that cultural conceptualization piece still comes into play, where they don't know what they don't know, you know.
Right.
And
Okay.
so they, when they come in for services, they are, they don't know what to expect or
Hmm.
how the service could be helpful for them. So I think that that's where, when I start working with them, usually by the time, like I usually do like psychoeducation about what a psychological evaluation is,
Yeah.
to just make sure that they understand the service and
Hmm.
understand what they are getting into before we certainly start. But usually, if they're asking for it, especially at this, I would say overall, at this
Hmm.
point of our Hmong history, like where we are currently at this point in time, if they are seeking a psychological evaluation, they have an understanding to some extent of what a
Hmm.
psychological evaluation is. They might not know the whole, like, they might not know, might not have a full understanding or understanding of how a psychological evaluation could help them in all aspects and the
Hmm.
impact of having a psychological evaluation, but they certainly know what it is, you know.
Sure.
um
Yeah.
that also, you know, another piece to consider is for some of our families who are less acculturated and are not English speakers, we have very compliant Hmong families or Hmong individuals, especially our older folks. They do what they are kind of told, you know, by people that
Yes.
they
Uh-huh.
respect. So if, as a therapist or a healthcare provider, you say, oh, you know, I think that you should go and get a psychological evaluation, they might come in for a psychological evaluation because they were told to. So it would be very important as a provider, a clinical provider of any type, to just maybe have that conversation with them,
Mhm.
or even connect them with a psychologist, so that the psychologist could have, like, if you feel like maybe that's out of your wheelhouse, have the
Mhm.
psychologist consult with that person to see if that would be appropriate. Or maybe you consult with a psychologist so that you
Mhm.
have the language to present that in a way that your client could really understand what they're getting into, and see if that is going to be helpful for them.
Absolutely. Yeah, that's so important. I teach that in my cultural competency trainings too, is don't assume, because head nods are, it's like our sign of respect of like, I'm listening, I'm here, I'm tracking, but it doesn't mean I'm in agreement. And
Yes.
so with informed consent, our clients need to know what they're doing and why, and to be
Mhm.
able to ask questions and to get the information so they can make that informed decision.
Yeah. And especially the more trusted you are, the more
Mhm.
they're going to be compliant, right? So as a Hmong
Yes.
provider, if you are working
Mhm.
with a Hmong client and you've had a relationship and they feel like you get them and and if you say, hey, I think you should go get a psychological evaluation and they don't really know what that is, they will do it, likely do it, but they
Yeah.
will not likely know the benefits of that and the implications of that.
Right. Yeah. We are winding down, but I want to spend a little bit
Yeah.
of time on speaking about autism, because
Yes.
I think I've heard several Hmong clients say they'll say like nu tua lo nu keng da shi nu ji zhong li nu tua lo nu keng, so people will ask like got tu mi tu they look normal, right? Like their
Yeah.
appearance looks normal because with things like
Hmm.
Down syndrome you can tell,
Yes.
right? But with autism you can't, and then depending on where they land on the spectrum, some are very
Yeah.
high functioning, and if it's hereditary, people may not have died. Like if it's with a parent or a
Hmm.
grandparent and they have symptoms, it may not be diagnosed. And then when it comes down and it's like, oh, this is my kid or my grandchild, and we're doing these testings. But or like let's talk about some of those dynamics of a
Hmm.
Hmong person. They're on the
Hmm.
spectrum and maybe they
Yeah.
are getting the help they need, but they're not. And then people are like, well, your child looks normal.
Yeah.
Mhm.
Autism is, gosh, we could spend a whole, maybe
We might have to
few
have a part
podcasts.
two. Uh-huh.
Yes. Autism is like a whole world on its own, because I think we are in a sandwiched generation right now
Mhm.
where the parents who still have young children who these issues are
Mhm.
coming up for them are
Right.
realizing, okay, my providers, my healthcare providers are telling me it's autism.
Mhm.
And then they are still also facing the older generation of not having any understanding of what autism is, right? Or
Right.
conceptualization of just brain differences and
Mhm.
just differences in development and presentation. And you are
Mhm.
right. If they present like there is a delay, then that's acceptable. I mean, that's more conceivable. It's like not a
Yeah.
big issue here. They might treat it not appropriately, like they might just dismiss the person, they might ignore the person.
Yeah.
However, the older folks still, treat that. But we are now in that sandwich generation where parents are like, no, I don't want to do that. I don't want to raise my kid like that. That's my kid. I love them. And the way that we are
Mhm.
taught here and socialized here is you are more involved with your kids. You are advocates for your kids. You want to
Mhm.
be just whatever they are doing, you want to be a part of that.
Right.
And so, yeah, if you have a child with a disability like autism, it is really hard for the older generation to
Mhm.
see that child and say, they look normal. They look
Yeah.
normal. They're able to talk. What are you doing to your child, right?
Right.
And
Right.
if you are a parent who is saying, no, they are saying that he has or they have autism, they
Mhm.
have these certain challenges, parents are going to be pushing back, right? And then you
Mhm.
as the parent also recognizes the struggles that your child has. So it
Mhm.
really is, it's hard. It is so hard.
Mhm.
But yeah, autism is the way that it presents is so hard. I think one of the very, very biggest misconceptualization with our understanding. It's not just Hmong who misunderstands this. It is the population at large. So autism is a brain difference and specifically a difference in social functioning.
Mhm.
It is independent of cognitive functioning. Okay, I want to
Mhm.
make that very clear. It's about how you interact and socialize and communicate and build relationships and share emotions. It has
Mhm.
everything to do with that. It has
Okay.
nothing to do with not nothing. There's nuances to that, but
Yeah.
it can be very independent of whether you are high functioning or low functioning, like your brain, how smart
Hmm.
you are or capable you are or
Hmm.
not. Okay, so
Hmm.
those are two separate things. So we have the spectrum because because of the brain difference in autism,
Hmm.
there are certainly ripple effects, if you will. Nice way to say that.
Hmm.
So brain, it is a difference in the brain. And then because of that, there are certainly differences in the way that it plays out cognitively. Okay.
Hmm.
So even though they are two separate things, they can be
Hmm.
interrelated. So,
Okay.
so what we find is that there's a lot of variability um,
Hmm.
in children with autism, the
Hmm.
variability in the way that they develop, the way that they function. So they might be very smart, like
Hmm.
intellectually very smart in one
Yeah.
area, and
Hmm.
then very far behind in other areas. So a very discrepant variability in the way that
Hmm.
they develop. That's a
Hmm.
marker for autism. Okay, so yeah, so the brain there is a brain difference, and because of that, it impacts their cognitive functioning. So when we have high functioning individuals who are autistic, right? That just means that intellectually, their brain
Hmm.
is capable of doing the tasks, right? The kind of more transactions of understanding and showing you that they could put two and two together. Like
Hmm.
they are really great at the cognitive tasks.
Hmm.
Um, but it doesn't translate the same when it comes to the social arena. Okay.
Okay.
So that's high functioning autism. Low functioning just means that um, cognitively they aren't able to do those tasks. The
Sure.
cognitive demands, they aren't able to do that. And then that also paired with the social challenges that they have. So somebody who's low functioning, you're going to see more of what, I think our Hmong people might deem as dual or like they might see
Yeah.
that as more of a disability, that's
Hmm.
more apparent. Yeah.
Hmm. Yeah. So really quickly, how would you describe very briefly to a Hmong person in Hmong what autism is? Because I think that would help us mental
Yeah.
health therapists too, who are maybe working with a parent, right, who has a
Yeah.
child who's autistic.
Yeah. So you want me to explain it in Hmong or the way that I would explain it, but talk
Yeah,
about it in English?
explain it in Hmong so we know.
Okay.
Because I you
Yeah.
you did a very great job explaining it in English, but
Yes.
how would we translate that into Hmong, like so
Yes.
people understand?
Yeah, that's a good one. Very good one. And it's not perfect. And I'm always
Yeah.
like looking for ways to do this, right?
Right,
I
right.
will, yep. So the way that I talked about it in English, that's the way that I will talk about it in Hmong. So I will say
Mhm.
that autism na ni yo it call it so that you look lu, okay? So that's first. So you look lu yung so mean chi, okay? That she called so nang do chi along the cooking j, lo
Mhm.
hockey nu lu bing su in it what na. So not cognitive or intellectual. OK，學手斬人哋啦，落幫助學你得到努力度，那是你this is where I have a challenge. So yeah, the geisha total geisha share for Beijing Mona, we have this word where you had to show on the phone them down.
Yeah,
Okay, so what that means is you don't have to say a lot, but they could pick up on
yeah.
the nuances of the language and the culture to kind of put those pieces together. Beijing
Mhm.
有冇 autism 呢？you usually okay, you have to be very clear
Mhm.
and be very straightforward. You hide a china lo you try kia ching payment ming elo temi
Right.
bao. You
Mhm.
hide chu you sack on the bao na lo yung bao the lo to king on the bao na tao na. That's just not going to work with our kids with
Mhm.
autism. You
Right.
usually be at here. You usually not just you have to 别错呀呢要别和别要ต่อไปโอเลนอลอยก็วีเลนอที่อยู่จะเทียบตัดตานะไอ้ตัวมีอย่างเดียวที่รีเป้าอยู่จะเทียบตัดตาไอ้ตัวมีอย่างเดียวthey're gonna get lost they're not gonna follow along or they're gonna get confused about why that might be so for example right อยู่ไอ้ตัวมีอย่างนะyou you behave a certain way you care there okay you tự重นะ you usually be a certain way right you have to be
Mhm.
very proper and then you 大家落出嚟นะ you could be whoever you are right
Mhm.
that's very confusing and so you're going to have to explain especially and we do that a lot more in general everyone does that but in the Hmong culture we do that a lot more the expectation of our kids to be proper out in the
Right.
community right to
Mhm.
save face and whatnot so things like that we have to be very clear cut like we have to be more explaining why we do that because they're not going to understand why we do that like it's going to be
Mhm.
confusing sending mixed messages so yeah so I do talk about that I do talk about sensory and restrictive interests so I talk about
Mhm.
all the symptoms right so when
Right.
it comes to sensory I give them the back story because I can't expect that Hmong people know what sensory sensitivities are. Okay, so I
Mhm.
go back to the basics of you bao cho you lu environment you in the you know na you bao cho you in TV you bỏ you more you bỏ you more on she you know lu you could taste right
Yeah.
you right so I go through all the senses and then I
Yeah.
say okay 就俾入面有冇 autism 啦lỡ bây giờ ấy bé nó like example bây giờ ấy bé nó na chúng con đi nữ tứ chỉ thông chế là tứ chỉ được đó na tất chỉ cho lỡ mà nữ lỡ nó ít nhiều giờ sao na bây giờ
Mhm.
ấy tứ chỉ chúng con đi những normal to bé sinh ra là cho
Mhm.
lỡ mà chúng con đi think saw lỡ okay
Mhm.
so or cho lỡ nhỏ chỉ tông tập hợp chân tàu là xí lỡ cho lại bỏ bón chê lỡ lỡ bây giờ
Yeah.
lên tới này so I do talk about some of those sensory sensitivities and that's the way that I talk about it giving them the psychoeducation and then filling in like give with examples of what that might look like if they were to have sensory sensitivities. And I do the same thing with rigidities,
Mhm.
explaining that usually don't learn don't lỡ do actually focus là trong những nhiều lỡ lỡ ở chỉ tàu lên tới lỡ lúc lưới do là tiền vụ yêu lên nó là na thì trong lỡ lúc lưới chỉ lên tới xưa na ấy dù
Mhm.
do mua con tới bảo lỡ nó chỉ trong mình sợ cho lỡ là trong lưới ở cho lỡ mình bảo tờ na ấy chỉ lỡ yêu chủ lại tới tiêu chỉ qua tới tiêu chỉ
Yeah.
chia they have a reaction to it so yeah, so I know that that wasn't really brief, but it isn't. It
That's
just
good.
can't be.
No, all of that is so good. I really appreciate that. My final question for you before we wrap up is, what would you say to somebody who's on their mental health journey? So whether they're having symptoms that's really impeding on their relationships and work, or
Mhm.
anyone like even if they're just starting out and they're like, well, I'm hearing these things, I might be on the spectrum, I'm having these symptoms. What would be your advice to somebody getting started?
Yeah, you know, I think so. Mental health is so important to everyone. Okay, to everyone.
Right.
And I think that that is just crucial for people to just understand. Okay, you are not free from mental health, even if you have good mental health. Okay. So I think healing and what we believe to be healing looks very differently for everyone. I am not here to preach that you have to go see a mental health therapist or seek a psychologist. That's what we understand here in mainstream America is that,
Mhm.
oh, if you have mental health, you go to a therapist, right? But healing comes in all kinds of ways. So find what works for you. What is healing for you? But make sure that that healing is also healthy and positive.
Yeah.
You certainly don't want to turn to healing methods that is going to be harmful or cause
Right.
more negative consequences. Okay, so that's kind of first and foremost. So I
Good.
think, again, everyone, that's very broad, but I think everyone has their own ideas of what healing is. And then I think ultimately, what I want people to keep in mind is that mental health, when I say mental health, everyone has mental health. The better your mental health is, it just suggests that you have a better relationship with yourself. That's what it comes down
Mhm.
to, you know?
Yeah.
So if something isn't sitting right with you, if you aren't feeling right about something, that
Mhm.
is a mental, we're then we're treading into the
Mhm.
world of mental health problems now, right? So
Yeah.
get that feeling right for you. So
Mhm.
that's how I would say gauge. That's what I would use to gauge mental health. If something doesn't sit right with you, something isn't feeling right, uh,
Mhm.
that is your boundary of where it's suggesting that you're treading into the area of your mental health is being impacted. So keep that in check. If you're finding that you are upset and frustrated and that persists,
Mhm.
then do what you need to do to take care of your mental health. So that's what I would say.
Awesome. I love that. So many good nuggets in that, and what you just said there. So, Dr. B, thank you so much for joining me. I think that the people are going to be super excited, to hear this podcast and to see it. Everything you said was super informative. So thank you again, and I hope that we can have another collaboration soon.
Yes, thank you, Pam. Yeah, I appreciate it. This is a very passionate, if you can't tell, just part of my life. And yeah, so I enjoy talking about it any chance that I get. So yeah, thank you.
Awesome. Thank you.